Hello, my name is Janet Higgins. I am originally from Newfoundland and recently moved to Colorado with my husband and 8-year-old son after many years of living in England. I first encountered PBC as a teenager when my childhood friend's mother was diagnosed. At that time, there were no available treatments and she eventually underwent a transplant. When I myself was diagnosed in 2009, I was lucky to have URSO available, and for 12 years it worked well. In the last 2 years, I've had to look at second-line therapies and clinical trials as my URSO response has declined. My personal journey has given me appreciation for how the PBC landscape has changed since I first encountered the disease. Like many of you, I am grateful for the research, innovation, new and emerging treatments that give PBC patients hope and help us manage this highly variable disease and lead fulfilling lives. It is my pleasure to introduce Dr. Gideon Hirschfield, who will talk to us about how the PBC landscape is continuing to evolve.
What a great intro. Thank you very much. So I'd just like to say, wow, it's a fantastic event that Gail has organized today, and all credit goes to her and her team who've worked really hard. And it's a privilege for me to be here today to talk to a full room on a Saturday morning. So I can't think of something better to do than talk to you guys rather than listen to my children screaming at me. We were last year in 2019, and I was trying to remember if anything's happened since then. Apart from the pandemic, there's been a few royal weddings, royal divorces, funerals and coronations that I've been watching. But in that time, I also think there's been a lot of dynamism about PBC. So, I really do appreciate, because I spend a lot of my time, and so do many of my colleagues in the room here, listening to patients living with PBC and other autoimmune liver diseases, that it's a very difficult disease to live with. It's a chronic disease. You come and see us in clinic, and we don't give you all the answers, and we don't give you all the solutions. But what I really want you to recognize is that the field is on fire. And, from where it's been with URSO and then OCA and then multiple new drugs that are going to be available and opportunities to not just treat disease but treat symptoms, I don't think you could be in a better position. And, Canada's an enormous place. I love living here. It's got a smaller population, but, you can be really proud that not only is the Canadian PBT Society punching above its weight when you think about the population of Canada and the reach that you have to have. It's just Ontario is the size of France and Spain, and let alone the entire Canada, 6 hours from side to side. It's phenomenal. But we're also lucky. I'm very lucky, and one of the reasons we moved back to Canada is to have phenomenal colleagues in each of the big major cities around Canada who have spent their careers studying PBC. So I'm privileged to start this meeting, but some of my colleagues speaking today have also done phenomenal work on PBC and understanding it. And I'm just going to give you that overview about PBC so you understand a little bit about how we think about the disease from a scientific perspective and how that then leads on to all the things that we're going to do. And, I'm lucky to be a physician scientist, and what that means is I spend half my time looking after patients and half my time staring at the blue sky and thinking, when I stare at the blue sky, what do I understand and what do I not understand? And that's something that we want also from our patients. There really is essentially no stupid question. Okay, so I found this quote quite fun: the importance of stupidity in scientific research. When we ask these difficult questions, we come up with answers. And understanding and living with PBC has many difficult questions, and we're getting better at answering it. But one of the beautiful things about science is it allows us to bumble along, getting it wrong time after time, and feel perfectly fine as long as we learn something each time. That's really important. And remember, your physician learns from you and learns from you every single time. So I've been looking after patients with PBC since probably, 2005 and a bit before, when I was in Cambridge. Okay, and we still learn when we're in clinic, when we listen to your journey and your symptoms, and we learn from what happens when you're in clinical trials and we try drug X, drug Y, and we see what happens and we learn. Okay, and the more comfortable we become with being stupid, that's me, okay, the deeper we will wade into the unknown and the more likely we are to make big discoveries and big differences. And that's what we're hoping to do. And we want to move away from this kind of concept, which is what you get, the first concept when you put PBC into Google. So this is from 1979. This is not meant to scare you. This will not happen on my watch. Okay? This is not what it's like to live with PBC anymore. PBC is a chronic disease, but it's a disease where we can make significant impact to disease progression and quality of life. And that's a phenomenal change, and that's because of science, clinical trials, and partnerships. So not on my watch now. When I meet a new patient with PBC, I tell them we're going to make a big difference and we're going to control your disease. And maybe we'll move to cure. Because we now have goal-driven care. We are aspirational and we are excited, when we see you and make a diagnosis to tell you that we have options and we can make a difference. We can prevent end-stage liver disease. We can manage associated symptoms. Transplant is phenomenal, okay? And one of my colleagues taught me transplant was nearly invented for PBC patients because they were the nicest patients, okay? And we still have transplant in our armamentarium, but we want to use it less and less and less and less. Because although transplant is phenomenal, we'd still like to prevent you from having it because it's not something that you can write a prescription for. And that's a big difference between medications and why treatments are so important and where we head. And you do run a challenge when you live with PBC because you're rare, but you're not that rare. You're common rare. It's good to be common, okay? So you're not on the ultra rare of the diseases with 1 in a million. You're not on the diseases with diabetes and heart disease, but you're actually quite frequent. 1 in 1,000 women over the age of 40 live with PBC. That is not uncommon. That means most family practices will have at least, each family doctor will have 1 patient with PBC. And if they're in a big practice, that means there'll be 5 or 10. Okay, so there's a lot of you out there, and we just have to continue advocating. And this is the ancient history. Okay, and there's some slides here, mainly just to prompt me to remember what to say. Don't worry too much about the details. But I want you just to see this is what used to happen if you lived in bleak northern UK, Newcastle, okay, which really did champion a lot of research on PBC, but it's quite cold. And unlike Ontario, there's not much sun, okay? But, outcomes before we had URSO and then OCA and then all the other second-line treatments, it was a challenge, and you can see why transplant was invented for PBC, because we wanted everyone to live a ripe old age. Now, this is something that my colleague, Professor Mason, will just touch upon, but I wanted you to see that this is the Canadian data. We've invested a lot of our energy in understanding what happens to Canadian people living with PBC. And Canadian people are very diverse, come from all over the world, okay? But focus mainly on the top part of this graph, and survival over 10 years is fantastic. That doesn't mean I don't recognize that you're living with symptoms as well, okay? But at least we've made the impact to length of life. We also want to work on quality of life. But what we learned from this and what Andy's going to tell us is that actually you're all very diverse. You're not all the same. You have the same name for your disease, but how you respond and how you live with it is different. And, again, for the Canadians in the audience, the majority, they'll know that First Nations have, a significant history in this land. And our patients who are First Nations heritage have really bad PBC. And we learned that from our studies. They need better treatments, different approaches. But, so diversity is important, but also the message is actually we're doing quite well. Our current paradigm, which I think you're all kind of comfortable with, is, and there are hiccups along the way, don't get me wrong. I realize there's a hiccup to getting your family doctor to the right test, getting a family doctor to the gastroenterologist, getting a gastroenterologist to do the next tests and prescriptions, etc. But our current paradigm is on the left of the screen, which is diagnose, treat with URSO, then think about second-line treatments. Our new paradigm, where we are headed in the next 10 years and already halfway there, is to personalize care, to be aspirational, to use therapies that target you as an individual, to understand what kind of PBC do you have, okay? You will all recognize for us that if you're diagnosed age 25, that's probably different if you're diagnosed age 85. If you're diagnosed age 50 and you're very itchy, that's probably different to someone who's asymptomatic age 70. And neither of you begrudge each of you. You recognize that everybody's different. But we have to move beyond just having one paradigm of care and get to the paradigm of care of targeting to how you present. So we will in the future tell you your risk. We'll tell you that we will aspire to have normal tests. We'll tell you that we'll try and resolve the disease, and we'll do everything we can to improve your quality of life. And we'll do everything such that those who need liver transplant get it in a timely way, but the majority of you will never need liver transplantation will be our goal. And of course, eventually we'll aspire for cure. And we'll do that because there are new therapies coming, and there's new science, and there's new partnerships, and there's investment from pharma. I mean, without this kind of collaboration, we wouldn't be where we are. And to put it into context, again, you're also, I like the introduction where they said how to find the PBC patient in the waiting room, go and find the nicest person. Okay, you'll know that the waiting room is bustling. Okay, wherever you get your care, you'll know that particularly those patients who've been coming to our clinic in Toronto, the programs get bigger and bigger and bigger. We're now on 30,000 visits a year, and there's no sign of any shortage of liver disease for the future. We're about to become the biggest thing in GI relatively is liver disease. And you're nestling there is this common rare disease, autoimmune, amongst viral liver disease, which we've cured, amongst obesity-related liver disease that we struggle with, amongst alcohol, which is a really big societal burden, and some genetic liver diseases. And you're nestling there. And you're nestling there thinking, what's going to happen to me about my liver? Is it going to go from health to cirrhosis and all the things that go with that, bleeding, malignancy risks, needing a transplant? But at the same time, how do I feel on a daily basis? How do I feel with this inflammatory bile duct disease? And why is it that these small bile ducts, which I didn't even know existed, are making me feel itchy, are giving me abdominal discomfort, giving me restless legs? Why do I feel so dry? And that's what we're trying to do, and we're trying to capture. And we want to make sure we find time in that busy liver clinic amongst the people whose quantity of life is more challenged in the imminent to the people whose quality of life is challenged over a long time, that they get the chance to do well. The dog likes my talk. This is great. Thank you. This is like Britain's Got Talent. Does anyone watch Britain's Got Talent, or is it just me? Okay. Simon Cowell loves performances involving dogs. Okay. They will get the golden buzzer. Okay. So I thank you. So in health, your liver is smooth. Okay. And it's a healthy liver. Over time, we don't want your liver to look like this, which is a liver that's been inflamed. And the liver is a really clever organ because it does everything it possibly can to plod along, which is one of our challenges. Most of you in this room will live into your late 80s, okay? So we have a long time to keep you healthy and feeling well. Getting to 65 is history. Getting to 85 is normal now, and that's our goal. And we want to live. Most of you will not get cirrhosis, but 1/3 of you will get cirrhosis over time. And that's when other complications arise. And when you have cirrhosis, it's quite clear what's going wrong. There are no hepatocytes. The cells, the factory, the hepatocytes and the biliary, the bile ducts are your factory in your liver. And as you get damage, there are less of the factory and more of the scar tissue. So no wonder it doesn't work, and no wonder you get complications. And then on top of that, as you get more progressive fibrosis, your symptom burden will increase. So symptoms in PBC are complicated by the fact that they relate to the disease, but they relate to the stage as well. And that's what makes it difficult as we progress. It's a live issue. So 1851, first description of primary biliary, it wasn't called PBC really, of primary biliary cholangitis. This was the classic, this is the infogram that was made, actually it's from 1851, from Addison and Gull, okay, of the woman with the lipid deposits. And now we still see this, but we see this less and less. We see it less and less with these patients who have devastating high cholesterol because of untreated PBC and devastating itch. This was a patient who walked into my clinic in Birmingham. So it's still there, okay? But we're doing better. And it's a live issue for patients. It isn't a historical issue. And it's not just a skin disease. Of course, it presented and was discovered and described by doctors because of the xanthelasma, the lipid depositions. But over time, people realized that wasn't the cholesterol in the skin that was the problem. It was the processing of bile, essentially. And under the microscope, and biopsy is important, we don't use it lightly, but we still need it. because that's the disease. You don't take your car in to go, my car needs to be serviced tomorrow because summer's come quicker than I expected. I wouldn't be very happy if I took my car in tomorrow and they didn't lift up the bonnet, okay, and actually look at the engine. And all they did was that bit where they stick the hose at the exhaust at the back and tell you that your car's all right, okay. I'm probably not going to be very happy to pay $1,000 for that service, okay. And it's the same with PBC. Sometimes, blood tests and quality of life scores and fibroscans and imaging won't be enough. We'll need to do a biopsy to really have a look under the bonnet. And that's when we see this lymphocytic cholangitis, these little white cells around your bile ducts. Jenny Heathcott, who many of you know, who started PBC really in Canada, working on it when she moved from the UK, called it a necklace, a pearl of lymphocytes around the bile ducts that was causing damage. And it's that damage that is ongoing. So yes, the majority of you in this room are over the age of 45, but by no means that's everyone. We have younger patients with PBC. Yes, the majority of you are female. Okay, so in fact, my practice is very female orientated because I do autoimmune liver disease, so that's very different to my colleagues. But some men get PBC. Yes, I can diagnose this disease on your blood tests. Anti-mitochondrial antibodies. So we can make a confident diagnosis with a simple blood draw that can be done anywhere. You don't have to come to a big town to get it done. And yes, there are some imaging findings and you're symptomatic, but importantly, there are treatments. Urso, obeticholic acid, and other off-label treatments, bezafibrate, and clinical trials, seladelpar, elafibranor, setanaxib. There's a whole host of things going on. Unfortunately now, the majority of the time that you meet me and my colleagues is when you're at home and you're seeing me in my office, as opposed to being in hospital, which is a big difference. And what's going on underneath the microscope here? Your immune system is attacking your bile ducts for whatever reason. Genes, and I'm going to talk about genes, and environment. I'm going to talk about environment. And they come together, bit of bad luck, and you've got persistent inflammation. And inflammation of the bile ducts leads to something called cholestasis. And cholestasis is when the contents of those tubes leak out. They're supposed to stay in the tubes, that bile. It's there for a reason. It's not supposed to leak out little holes in your bile ducts because that's what drives inflammation and your symptoms. And that leads to liver scarring. And it's a cycle, and it's ongoing. And we're trying to interrupt that cycle for you so that you don't progress, so that things resolve. And we can then measure our success with that by measuring your blood tests. So your ALT is measuring inflammation. Doesn't mean autoimmune hepatitis, it just means inflammation. Your ALK phos, okay? I know that's not the be-all and end-all for PBC, and quality is as important as measuring biochemistry, but your ALK phos is that blood test that we measure to look at the damage from the bile ducts. And then we're always watching what's happening. Is your spleen getting bigger? Or your platelet count falling? What does your ultrasound look like? And it's a cycle. It's an immunobiological cycle, okay, which starts off with injury to the small bile ducts and then becomes chronic and persistent. And despite your body's best efforts, you can't get on top of that without the assistance of our therapies that are designed to shuttle, to put that bile and those bile acids back inside the tubes and remove them from causing further harm. So when we think about what you might ask and what I may ask when I'm looking after patients with PBC, what's the problem? What are you going to do? Is treatment optimal? Does the evidence support my approach? And that's kind of going to therefore be framed by how I understand what causes PBC, which will then help me answer those questions. And we are moving forward, but we should always look back. Okay, so Sheila Sherlock has this beautiful, she was the founding professor of hepatology, really got the field on fire. And in 1968, she drew this really beautiful figure, which still stands true more than 50 years later. Okay, what are the causes of chronic cholangitis? So chronic cholangitis is what you have. Chronic means persistent, cholangitis is inflammation and damage to the bile duct. She said, is it abnormal bile salts? Well, it kind of is, actually. And look, our treatments improved that. Could it be infection? Professor Mason stepped out the room, so I can say no. But he'll tell you that it is, okay? And maybe he's right, and maybe I'm wrong, and I'm the one who's stupid, and I've got it all wrong, okay? And we will find that there is some infection. There's something that we don't understand in the environment that might be many different forms of infection that triggers the attack. It's not cancer, but it could be changes in how bile ducts develop. It is about the immune system. And when we use the word chemical/drugs, what we now mean that to mean is the environment. We are surrounded by toxins that we don't even know. There are toxins that are clear to us: smoking, drinking. I mean, that's obvious. Okay, there are toxins if you get on a bus in downtown Toronto, the air quality is not very good. Okay, whatever you breathe in. Various different parts of Canada, you might be the person who grew up next to a Ford factory, or coal mining and gold mining, and there's evidence around environmental triggers from those kind of environments, because what does the biliary epithelium do? It excretes environmental toxins. Okay, so where might your immune system meet an environmental toxin? It might meet it in your bile duct. Okay, and that might be one of the reasons. But then we fast forward to 2023, and we just look at the top row of this figure. Again, not for you to focus too much on the details, but PBC is the top row. These are the other diseases we're writing for this review for Gastro, one of the journals. There are tiny little holes in little bile ducts because of the immune system, and that leads to the inflammation, that leads to your laboratory test being abnormal, and we have then treatments, and that leads to progression if we don't get it right. And again, this is a pretty picture. It's not supposed to be something that you need to have a photographic memory and then recite to me. But on the left, you have a pretty picture of the immune system, and on the right, you have a pretty picture of how the liver and the bowel are talking to each other. They are in constant communication and bidirectionally. So the pretty picture on the left is telling you that in immune-mediated liver diseases, there are lots and lots of different cells, B cells that make antibodies, T cells that directly injure tissues, and then cells that control those responses. And they are all interacting in cascades and subtly differently in you, and that's leading to you attacking your liver rather than living with your liver. Because in fact, we all live with this all the time, and in someone who's got an autoimmune disease, something just goes awry, and once it goes awry, it's all about balance. It's all slightly out of sync, and then because it's out of sync, the immune system is winning as opposed to the defense system. And then what we've learned is that our liver and our bowel are tightly linked and are in total communication, including the bugs in your bowel, including the bile that comes out of your liver that feeds the different bugs in your bowel, and then a cycle. And that's impacting inflammation and damage to the bile ducts. And then what we've learned, and again, nice pretty pictures, but it's important just to show you the pretty pictures, is that there are very specific molecules in your liver cells and bile ducts that we can target with drugs. Okay, so urso is the hepatologist's friend. It is a bile acid, which we find it in a high concentration in polar bears, and it was turned into a drug via Chinese herbal remedy and then turned into a pharmaceutical. Okay, but it's given to you in gram quantities, and in gram quantities, it's a bit like a blanket, which is very, very reassuring and very soothing. Okay, and we smother that on your bile ducts, and it seems to help. It seems to mop up a lot of these damaging bile acids. But where the field has moved is to say, when I look under the microscope, all those clever scientists, there are molecules. One molecule is called FXR. It's a nuclear hormone receptor. Another pathway is called the PPAR pathway. And these are controlling at a very, very microscopic level the ability to excrete and make bile and cholesterol and inflammation. So we now target that. So obeticholic acid is given, urso 1,500 grams a day. Obeticholic acid, 10 milligrams a day, 5 milligrams a day, highly specific for FXR. And then we're targeting PPARs. Okay, so we've got bezafibrate, which targets lots of PPARs. We've got seladelpar, which at 5 to 10 milligrams is targeting PPAR delta, one subtype. We've got elafibranor, which is also targeting pan-PPARs, etc. Okay, so we're targeting right down to the molecular level these pathways, and if we can get these pathways to upregulate and push them a little bit harder, we get rid of some of the bile acids which are causing the inflammation, and we seem to make a big difference. So then what happens? I'm afraid it's good old-fashioned, it's a potpourri of risks and bad luck to get PBC. What are the risks? Something in your genes. Something about your age, something about your gender, and then something about the environment. And then there must be some bad luck, because whatever's in the environment, and the environment almost certainly explains a large proportion of why you develop PBC, if you're never exposed to it, well, you'll never get PBC. I mean, because you didn't have the bad luck to be exposed to that environmental trigger. The problem is we don't know which is the environmental trigger, and it's quite likely when you see PBCs all over the world that there's lots of environmental triggers. Each of them is slightly different, but similar enough that when you combine it with genes and gender and epigenetics, that comes together, and then the disease is triggered. And so I'll just talk a little bit about DNA because it's important for you to understand this is not a genetic disease, but it's a disease with genetic predisposition. And it's also cool for the Canadian PBC Society because the first GWAS on PBC was published from Toronto, okay? And then so there's a significant heritage in patients across Canada giving their DNA to help us understand PBC. And then there was a slew of collaborative work, UK, Italy, China, Japan. We now have a global collaboration where we've understood the very subtle changes in your genes that cause PBC. And what happens is a sliced cheese. This is Swiss cheese. If any of you going on holiday wants to go somewhere nice and have some nice food, Swiss cheese is lovely, and you pile it up, okay? And that's what is happening to you as a patient. There's some genetic susceptibility. These are not rare. This is not like sickle cell or cystic fibrosis. You're all slightly different, but not hugely different. There's a predisposition to autoimmunity. You're predisposed without you even knowing to get autoimmune disease. But you might know, you might have celiac already. You might have thyroid disease already. You might have rheumatoid arthritis already. So you may have a clue that you or someone in your family is autoimmune. And then something comes along from the environment. That's the bad luck. It all comes together and we have persistent dysregulation. And then that's how you present. And because each of those cheeses has a slight different flavor, a slight different size, a slight different sort of dimension, you're all different. And that's why some of you will have very mild disease, and some of you will have very, very significant progressive disease. That's why some of you will have no itch, and some of you will have very bad itch. That's why some of you will respond to URSA, and some of you won't, etc. And it goes on and it goes on. And that, of course, is the challenge for us, is the diversity and individualizing the care. It's clearly familial, but it's very rare that anyone in this room will have someone in their family have PBC. About 1 in 20 of you will, so we've got 100 people. So it's quite possible, more than 100 people, that if we had 100 patients with PBC, that there are some with families. We've started to see, I've now got a couple of patients in my program where one brother's got PSC, a very difficult bile duct disease, and the other brother's got PBC. Really very unusual. Okay, again, we've got one brother who's got PSC and one sister who's got PBC. So, genes are clearly important, and it's I can't exclude an environmental trigger, but it's relevant. And then with all this great DNA technology, we'll eventually find that some of you, very few, have got what we would call a phenocopy of disease. So you've got a particular gene that causes really dominant PBC. And we'll learn that as we do. We're going to continue doing more DNA sequencing. And this is just an example actually from PSC, where they found one family in Scandinavia where the whole family gets this disease and gets inflammation in their colon. Really interesting. They spent 10 years working out what it meant. They got 5 different mice to prove that what it was doing. Okay, but then when they looked at 4,000 patients with PSC, they couldn't find anyone else who had that mutation. No one. Okay, so it's a phenocopy, but it gives us insights, and it's quite possible, again, to speak to the diversity of living with PBC, that a few of you have got something slightly different. That's why you've got what you have. So this is what we published first back in 2009, which was work which took us from really around 2007, and it's a gene study. It found that your HLA, and again, I'm sure some of my colleagues will mention that, is slightly different, and some of your immune pathways are activated in PBC. And now we can fast forward to, an international study. Heather Cordell from Newcastle, who's an amazing mathematician, has taken on your challenge and has pulled all the data from all the studies, in Europe, in China, in Japan, and looking for genes, and that may help us find drugs, okay? With drugs for the future that are specific. But it's not as easy as that, because we tried that. When we first found the particular pathway, IL-12, was relevant to PBC, we did a clinical trial with a big pharma, and this is the study we published nearly 7 years ago. And ustekinumab is a drug that's very good for Crohn's disease, in particular, and some other autoimmune diseases. But it didn't seem to be good for PBC. But I'll just caution you, and I'll just first of all thank you for taking part in clinical trials, but I'll encourage you to continue to take part in clinical trials, because it's the only way that we learn. Because actually amongst these patients who got ustekinumab, there were a few who had phenomenal responses. So would never be picked up in the big trial, but there were some patients whose ALT phos just vanished. Okay, so it makes us think, we learn how to do clinical trials. So how we developed that trial in 2016 is different to how we do trials in 2023. And this is just another slide just to remind me to tell you that, there were in fact people who responded to this drug, which was based on the genes that we'd found. But it wasn't enough to make it the drug. But we, to find out whether a drug works, we ask a lot of you. The first thing is always, is the drug safe? Okay, that's a lot of work. Do not underestimate it. The second thing is, have I got the right dose? It's not as easy as you think to know what dose to give. And what then makes it challenging, the dose that I might give for, say, rheumatoid arthritis or for ulcerative colitis, it may be totally different to PBC. So if I come along and tell the PBC patient to take that dose, and it may look like it doesn't work, but all I've done is give the wrong dose, okay? And you can see how hard it is and why we're so keen that we continue to involve you in our trials. The environment is a chat which I think other people will talk about today, but the environment shapes us, okay? Why do we have more metabolic disease of the liver? Well, we're all putting on weight. Why are we putting on weight? Well, we could be healthier, and we live in an obesogenic environment. So our genes have not changed over thousands of years, but the amount of exercise we do, we no longer hunt and gather, okay? And we gather, Coca-Cola, which is, not 0 calories. And that will lead to a different environment, a different expression of our genes, and that's the same for PBC. It's not just for common diseases. And then at the bottom, for any of you in the room who've got celiac, 6% of our patients will have celiac disease. Celiac is an environmental disease. Take away the environmental trigger, and the damage that you see in the small bowel disappears. So imagine if we could find what the environmental trigger was for PBC, we would focus on removing it potentially to try and help you heal your bile ducts. So then we have, when we understand what causes PBC, we've got research on the right-hand side, we've got why everyone's got disease totally, and we've got this balance of your genes. Some genes we know, some genes we don't know, genes that talk to each other, genes that are then expressed in different ways about how potent they are, and then how the genes interact with the environment. And if your genes never meet the bad environment, well, then you'll never know that you had those genes that were slightly different to your neighbor. If they do meet the environment, then you might find out. You get an autoimmune disease, it might be PBC, it might be something else. And what we want to eventually do is catch on with what everyone else is doing, which is where we study the whole of you, and that includes your quality of life and how you feel, and all sorts of things about your diet and your environment. And we basically sequence every last bit of you: your genes, your protein, your metabolome, your urine, what your bugs are doing in your bowel, and we put that all together. And we are doing that, and we are seeing that happen in other diseases, and that's leading to personalized care. That's leading to understanding disease in a completely different way. So I'm sure I've run over, but Gail's probably too polite to tell me. Okay, I've got 2 minutes. Oh, I'll slow down. I'll take my time. Okay, so this should say the 50 points for PBC care, but I'll summarize it down to just 5 points, so I use my 90 seconds now appropriately. So, I gave you a flavor for what PBC is. This chronic inflammatory autoimmune disease, mixture of your genes and your environment, and persistent inflammation. But I hope I told you the future is going to be different. And I like to finish on the 5 TCLD, Toronto Centre for Liver Disease, points for PBC care. Okay, so this will frame what you then hear for the rest of the day and the discussions that you have now and the discussions that you can have with your own physician providers. Number 1, advocate for a confident diagnosis. If you get the right diagnosis at the beginning, you'll get the right therapies. Why do we write guidelines and care pathways? Why do we want licensed therapies? It's because we want everybody, wherever they live, to have the same standard of care. It shouldn't matter where you get diagnosed with PBC, then you're then on the correct journey. And that's, it's one aspect of your life. We realize that. You've got many other things, but given the label, you then want the right drugs. So currently you make a good diagnosis, and that's really important, because if it's a clear diagnosis, you'll understand it. You'll understand your symptom complex better, which is how you cope living with quality of life detriments. And you'll know that the drugs that you take are important and why you put up with them, because some drugs will have side effects, some drugs won't. Okay, but if you understand the importance of taking it, you'll make a compromise, and maybe you don't like it, but you know why you're taking it. Then we want all our patients to get ursodeoxycholic acid. This is our current standard of care. It will change. We really feel that in 20 years' time, we may be able to move beyond URSO to things which are so much better and skip it by having selective therapies. Why not? Okay? We should manage your symptoms in parallel. We'll only manage your symptoms if we find time in clinic to ask you, okay? That can be difficult. You're busy, we're busy, clinic appointment times are short. Discussing symptoms is not always, you're not always in the mood to talk about your symptoms. Some days you do, some days you don't, okay? But you do that over time because, like it or not, if you're looked after by a PBC doctor, you're going to know them for a long time. So you have the opportunity on multiple clinic visits to explore how you feel, and we can then help you live with that. For everyone, what is your risk of disease progression? What is it about your disease that says it's either mild, moderate, or severe? And if it's moderate and severe, can we aspire to do better than just ursodeoxycholic acid? We already have a obeticholic acid, which has really changed the field. It changed the field because it showed everyone you can get a new drug on the market for PBC, which is to your advantage, without doubt, because that's why there are now lots of people who also want to get drugs on the market for PBC, because the pathway became clear. And then you have the opportunity of repurposed therapies, bezafibrate, fenofibrate, clinical trials, seladelpar, elafibranor, setanaxib, and IBAT inhibitors for itch, which you'll hear about, and lots of other companies in the wings. And with that, I'd like to say thank you and wish you a great success.